I'm going to speak in Spanish. Sorry for that.
No, I'm sorry,
I will introduce you, okay?
Okay.
Bueno, muy buenos días a todos. Bienvenidos hoy al nuevo Super Thursday. Estamos el día de hoy con el profesor Adam Arthur. El profesor Adam Arthur es neurocirujano está con nosotros desde Memphis, Tennessee. El profesor Adam Arthur es un neurocirujano extremadamente reconocido en el medio. Hasta el año pasado fue el presidente de la Asociación Americana de Neurointervencionismo, una sociedad que se llama el SNIS. A nivel internacional, el profesor Adam Arthur ha liderado múltiples proyectos desde el ala del neurointervencionismo, desde la introducción del dispositivo web en Estados Unidos, desde el tratamiento con dispositivos desviadores de flujo en Estados Unidos, hasta en la actualidad viene siendo co-investigador o investigador principal en un estudio bastante extenso en donde se utiliza la embolización de la arteria meningia media para el manejo de los hematomas subdurales crónicos, especialmente aquellos que tienen recurrencia. Hoy tenemos al profesor Anapro con nosotros. Esperamos que esta charla sea del gusto de todos ustedes. Las preguntas que se quieran hacer a través del chat, bienvenidas todas ellas, o si quieren preguntarle directamente al doctor, pues también es un tema que genera mucho interés. Entonces, están todos ustedes bienvenidos para hacer ese tipo de preguntas. Okay, Dr. Arthur, first of all, I would like to thank you for us in the neurosurgical community here in Colombia. It's a very important topic to talk today. It's really, really interesting to know how will be the next step in the treatment of a chronic subdural hematoma. Would be really, really important to know your point of view. Remember at the end of your talk, talking about the future of the neurosurgical community, especially to the neurovascular surgery. How is the process to get involved in the new techniques, new treatment? We're really glad to come with you for today, Professor. Thank you very much for accepting the invitation, and it's a real pleasure for us that you illustrate us about the middle rangeal artery embolization for the management of this specific condition in the neurosurgical community. Doctor, please go ahead, and if any question during your talk, we will interrupt, or especially at the end. What do you prefer? If any question is better at the end or during your presentation?
Whatever's easiest.
Okay, perfect.
One thing before you begin, this meeting is going to be recorded. Do you have any problem?
No problem.
Okay, thank you very much.
So while I have the presentation up, I can't see your faces. So just speak up if you have a question or concern. But I'll leave some time at the end for discussion also.
Okay. Go ahead, Professor.
Yes, sir. Thanks for the opportunity to talk to you. One of the things I want to say is that this is work that I've done in collaboration with Dave Fiorella. We worked together on this trial. The other thing is disclosure. So what I'm going to explain is this idea about doing a trial for the chronic subdurals. And this is an idea that Dr. Fiorella and I had 4 or 5 years ago. We initially brought this to Medtronic to ask them to fund the trial, and they decided not to initially, and then we went to BALT. So we are moving forward with an FDA trial with BALT. So obviously I'm not paid for this talk, but I am paid by BALT when I'm doing work as a principal investigator of the talk. I don't get any more money if it's successful or if it's not. So everyone understands what a subdural hematoma is, sometimes called chronic subdural hematoma or non-acute subdural hematoma, NASH, and it can be mixed and includes some acute hemorrhage as well. This is a big public health problem. It is the most common neurosurgical diagnosis among adults. It's a very common cause of morbidity and mortality. And the World Health Organization has classified it as a sentinel event. The other thing that's interesting is as our population gets older, this is actually one of the few causes of dementia in the elderly that we can fix, that's reversible. And we think there's probably more of it than we realize. The other thing I'm going to say is, as a surgeon, all of us in neurosurgery have seen this many, many times. We all have ideas about how to manage a chronic subdural. I have my own ideas that I developed over decades, but these ideas are not very well scientifically tested, and there's a high rate of failure. So I run our morbidity and mortality rounds here at our center, and subdural hemorrhage, chronic and acute, is the most common diagnosis for a patient to be presented at our morbidity and mortality rounds. So I have references in the bottom if anyone wants to look this up, but it's a very common disease. We think it's becoming more common, both because we have older patients and because there's more use of blood thinners. And there's a VA study that indicates that within 10 years, we're going to see over 60,000 cases a year in the US alone. So that's twice as much as all subarachnoid hemorrhage, aneurysmal and otherwise. Here's more evidence from a paper 2 years ago in an administrative database that shows the increasing prevalence and the fact that the prevalence is increasing particularly in the elderly. So our patients are becoming more numerous and they're becoming older in this disease. And so, one of the things we have to think about is why this happens and why they recur. And so there's research that I'm going to go over that indicates that the chronic subdural problem is not just because there was a bleed. We think there's a vicious circle where once there's fluid and blood there, your body is trying to fix the problem and create more of a problem. The way this works is that the membranes on the inside of the dura proliferate. And we see this when we operate. We see these membranes that have capillaries, and those capillaries leak. They leak more fluid. That fluid creates more fibrinolytic breakdown products, and so your body cannot keep up, cannot absorb the fluid fast enough. So I'm going to use this illustration from a paper in the Journal of Neuroinflammation, some very bright investigators from the UK. Here's the external membrane and the internal membrane, and you can see the chronic subdural collection. When your body senses that there is this chronic fluid there, we see an upregulation in interleukin 6 and 8, and you see more cells come into that area to try to fix the problem. Then those cells create an environment where you make new membranes to try to scar down the subdural membrane. But there's exudation of fluid. So you get an increase in fibrin breakdown. And then this creates this pathway here where these highly permeable capillaries are leaking factors that create more breakdown of the fluid that's already there. And so there's more and more fluid being produced by the membranes that are trying to fix the problem. So you see these little neovessels. They're not normal, these membranes. And they're always fed by the middle meningeal artery, never from the pia, never from the brain. In fact, there's work from Japan that shows that in chronic subdurals, the middle meningeal artery is bigger. It grows. It becomes larger to feed these membranes. And this is statistically significant. And then we know the membrane's pathological because it's also enhancing. It's very vascular. So you have these leaking membranes and continuous recurrent low-level bleeding and fluid exudation, and that is happening too much for the blood to be absorbed by the veins. So what do we do before we begin to study this? I want to make sure, are you all there? It just got quiet.
No.
Okay.
We are listening to you very, very good.
Okay. Sorry, I don't want to be talking to myself. It's early in the morning. So
Ajá.
this doesn't usually fix itself. So as a surgeon, you have to do something. It doesn't go away on its own once you get a good fluid collection there and the patient's symptomatic. So you can do a full craniotomy. We used to do this 20, 30 years ago and pull the membranes out. That's become less fashionable because of the worry that that's traumatic. You can just do burr holes and irrigate. I do this often, usually with placement of a drain. Or there are these self-contained drainage solutions like the SEPs, where you make a twist drill hole and you push the bolt in and you attach it to a drain. But all of these are invasive procedures where we take somebody who may have atrial fibrillation or some other reason to be on blood thinners off their blood thinners. And all of these require some recovery and drainage in the intensive care unit, often with the patient kept flat. Remember, this population is already old and it's getting older and older as we will move forward in our careers. And so they have other medical problems that create an issue. So there's high rates of recurrence. You can do a perfect surgery and the fluid comes back, sometimes very fast. There's high rates of patients having heart attacks or lung problems or other issues. The World Health Organization says that if you diagnose a chronic subdural hemorrhage, the chance of the patient dying of some cause in the next 12 months is over 30%. And it's probably partially because of the disease and partially because they're old and they don't recover from this well. So if we could come up with another way that is minimally invasive, we might be able to do some good. It's not as sexy as fixing an aneurysm, but it could be very important. But we don't have very good evidence, okay? We just have been doing this. There's no randomized controlled trials. It's old enough that we just started doing it. But we know, as I said, 12-month mortality from this disease is 30%. In-hospital mortality is 5 to 10%. So, you know, we're not doing great. It may be just because they're old, but we're not doing great. There's an opportunity to do better for these patients. Here's some of the evidence from a meta-analysis in 2014 indicating some of the numbers that I've been telling you. So there's some evidence that this is a cerebrovascular disease, and if we come up with an endovascular management, it could have a major impact. So the strategy here is to achieve devascularization of the abnormal membranes and reduce or eliminate that continued microhemorrhage, break this cycle, and allow reabsorption of the subdural fluid to change this dynamic. So what this has been done with traditionally in the past is polyvinyl alcohol, or PVA. And I believe that a liquid embolic like Squid or Onyx or even NBCA is superior. The reason why I think that's going to be superior, although it's not proven yet, is that I want to get the membranes way out in the dura. I don't want to just coil or PVA the proximal middle meningeal artery. I want to be all the way out in the membranes out here. So I'm going to show you why I think that's the case. So here is a microangio run of the main branch of the middle meningeal artery over a subdural. So you can see we're out very distal, and you can see the abnormal membranes. Angiographically, you see them as well as I can see them in the operating room when I do a craniotomy. They're very abnormal. It looks like cotton wool. And here's the same case with injection of a liquid embolic. So you can see the penetration out distally within those membranes, filling the abnormal vessels, direct prevention of those vessels continuing to exudate fluid within the membranes. As a surgeon, I want to be very specific. I don't want to just block the artery down here. I want to get it right there. And you can see that you get collaterals too. If you get a good injection with a distal wedge, sometimes you can only do one branch rather than having to separately catheterize both major branches. You can see the embolizate very well. You can see it on fluoro. You can avoid the dangerous anastomoses I'm going to talk about at the skull base, and you can know that you've done what you needed to do. It's fast, it's safe, it's permanent. I do these under general anesthetic so I can see what I'm doing very well. So here are some examples. Here's one of the first cases I did that at 4 months is resolved with a good resolution of symptoms. Here's one that is a little more acute. It's isodense to brain, not truly acute. And in 4 months, you can see a complete resolution with no craniotomy. Here's one of the first cases I did that really blew me away. So you can see tremendous mass effect. This patient had a pronator drift on the left and was falling. I embolized his middle meningeal artery, and his symptoms improved in 3 to 4 days, very quickly. And in only 3 weeks, you can see he's got this improved scan. In fact, his scan in 3 weeks was read by the radiologist as normal. It's not normal. There's still a little mass effect on the ventricle there, but it's certainly much better, and symptomatically, the patient experienced a major change very quickly with no surgery. So I'm going to show a couple of cases and talk about some details. So I do believe this is better for general anesthesia. Can you catheterize the middle meningeal artery with a awake patient? Of course. But the wire passage, if you're going to get very distal, is painful. And the DMSO, if you're going to use a liquid embolic, is painful. I like to have the patient all the way asleep so that I can see and roadmap and be very precise. In cases where I've had to do it awake, you can use lidocaine, but it still hurts. I've been doing these generally radially, using a 5 French Simmons 2 glide catheter. But if they have an arch that means I should go femoral, it's no problem. I can go femoral. If I can't get distal with a small microcatheter, I'll use a dual lumen balloon, and I'm going to show that. Most of the cases I've done have been with an echelon 10, some with a duo, and some with the balloon. I always look at a common carotid run first. Look for the ophthalmic, look what is feeding the ophthalmic, and look for the subdural. I want to get to the subdural. So selective external carotid run to document the anatomy, and then take the middle meningeal artery out as distal as possible, typically in the posterior branch. So here's a picture showing good anatomy of the middle meningeal artery, and there's the posterior branch that I'm generally going to. But you know, sometimes you have to do more than one catheterization to get a complete occlusion of the territory. So here's an example of superselective angiography. I do use lidocaine and verapamil, particularly in awake patients. And then I'm an impatient man, and so if I can get it very distal, I don't have to plug and push and wait. I just inject. And usually it's just one injection, and then I pull the catheter out. I haven't had a problem with the catheter being stuck at all. You get distal penetration. And then you want to check post-embolization and make sure that you did what you thought you did, make sure the brain is okay. And then I usually do a cone beam CT on the table to document the size and the material in the subdural. So here's an example of bilateral, very large, acute on chronic subdural. So this was a very symptomatic elderly gentleman, sort of a typical picture we see. Here's your initial external run showing you faintly the middle meningeal artery. Here's the selective run. And then here's this injection, which I showed you a minute ago. Sometimes there's a little bit of a zigzag right as it goes through foramen spinosum that can be a little difficult. In this case, it's pretty straight. And as you reflux, you have to watch to be careful because you don't want to get near the eye or the cranial nerve. So here's one side, here's another branch to make sure that we get all of that territory very well. And then here's the cone beam CT afterwards, where you can see the artifact from the material in the pseudomembranes on both sides. And after drainage, you can see there's some air in the head. And you can see we put drains in because this was one where we did embolization prior to drainage to reduce the risk of recurrence. We've done this both as a standalone in patients that we thought, you know, could get away without drainage, and then sometimes as a pre-op maneuver to try and avoid recurrence. So here's another case that's interesting. It's a 65-year-old gentleman on Eliquis, and he presented with a subdural, and they stopped his blood thinner. Very common. Well, in the hospital, he had a stroke because they stopped his blood thinner. So here's his subdural with some mass effect. He was symptomatic. And then here's his stroke. He has a PCA occlusion. And this is the typical no-win situation that we see with older patients. I want blood thin, I want blood thick. We have to do one thing throughout the whole body. So in this case, transradial thrombectomy using ADAPT with 3 max and a soft 024 wire. So there's the pre-picture. I'm sorry, it's not so good. And then here's the post picture showing recanalization of the PCA. You're already there endovascularly, so you can then just change and go to the external, get up. Here's a video showing that it's a fairly quick catheterization to go straight out over the subdural, getting very distal. And then here's the injection. And then here's the injection of liquid embolic, Onyx or Squid or NBCA. You know, I don't know that it matters. We're going to be using Squid in the trial. And then just pulling the microcatheter out. So getting the other branch, you can see you have to navigate a little bit here to make sure that you get your catheter up distal to get the entire territory. Is good training because it's very safe. It's a good thing to train fellows to do before you let them do things inside the brain. And then here's the other injection. Sometimes during these injections, you do see some canalization of branches around the sagittal sinus. Sometimes you see even arteriovenous fistulas. I've not seen a problem yet. I've not seen a big leakage of liquid embolic into the subarachnoid or subdural space. Even when we have fistulas, we just fill them and they go away. So there's an example there, I think, of collateralization probably into a vein. You see that? So there's your cast. And within 3 days, he's seeing some symptomatic improvement and an improvement in mass effect on CT. 3 days. This surprised me very much when I first started seeing this. And he did very well and was out of the hospital in 3 days. And because we didn't do a craniotomy, we fixed his subdural and could immediately start his blood thinner, hopefully prevent him from having another stroke. So here's another case. This is a patient with a shunt, overdrainage from the shunt, large subdural, symptomatic subdural. You've seen this before. It becomes very easy. But in this case, you have to see that the branch you want to get has two problems. One, there's a zigzag. And two, there's a recurrent meningeal anastomosis that goes to the eye. So you have to be very careful. I have colleagues not in Memphis, but in other places that have caused blindness of the eye from this. So I can't get around the zigzag, and I don't want to embolize the eye, the retina. So this is a great opportunity to use a dual lumen balloon. So here you see the balloon into the zigzag, but the balloon is protecting the recurrent meningeal. And here with the balloon inflated, you can see good filling of the distal branch. I'm injecting from more proximal than I want. This is not ideal, but many of my patients are not ideal. I can still get the embolic distally, and the balloon is protecting the recurrent meningeal. There's the deflation of the balloon. So this gets to this little point I want to make using some figures from good colleagues like Max Shapiro in New York. The two major risks here are anastomoses to the ophthalmic artery and uncontrolled migration into the petrosal branch. Both of these are at the skull base, or anastomoses that come down to the skull base. So if you get distal, it's very easy to avoid this, but you have to be aware of this. And it's one of the reasons I don't like PVA, because you can't always see PVA. You don't always know how much reflux you're getting. So here's a summary of all these anastomoses from neuroangio.com, showing some of these branches that you have to be aware of and watch for on angiography. And so if you have a middle meningeal branch, as you do in this case, that arises, from the ophthalmic, obviously it's not something you're going to be able to do very well with. So you're not going to get up there easily. If you have a meningio ophthalmic artery, in this article from Philippe Gaillud going through the superior orbital fissure, you have to watch out for that. Again, it's not a good case for embolization. And if you have an anatomic configuration at risk of a complication, where sometimes when you have that wedge microcatheter, you can see the anastomosis, you have to get beyond it. You have to get past that and make sure you don't reflux to that. It essentially means your no reflux zone goes up to where the branch is, away from where the skull brace is. And then here's, again, Hurdle's Canal showing you the meningolacrimal artery. So you have to go past it and not reflux back to that. This is well reported. As I said, if we continue to be careful and hopefully lucky, we won't have a facial nerve or blindness from this. We haven't so far with 70 or 80 cases at my center, but it can happen. So Boris asked me to talk about the future of the field. I think there's several things in the future of the field that are exciting. Obviously, thrombectomy has been a big deal. We're able to help a lot of people. The miniaturization of devices so that we can treat with more precision is important. The improvement in the angio equipment. We're putting in a new Siemens set now. You can see more. I think this is a big step here. If we can show that we can do good work here, there are more of these patients than all of the aneurysms and AVMs that need to be treated in a given population. So the other thing I like is it's not an emergency. I have children, I have a wife, I like to drink wine and eat food and live a life. So I run into the hospital in the middle of the night for a thrombectomy, but it's nice to have some work during the day to do for my angio crew. So this is something that we're going to study. So STEM is the trial that we're doing. It's an FDA multi-centered randomized controlled trial in the US, Germany, France, and Spain. We're going to examine both the potential to avoid burr holes and do it as a standalone therapy and the potential to decrease recurrence with surgery. And we're going to look at both radiographic and neuropsychological endpoints with blinded adjudication that is independent. So you can find it on FDA.gov. There are some German sites that should be enrolling any day, many US sites coming up. I'm excited about this. Basically, when a patient comes in, we put them into three flavors. Either they need an emergency surgery, not part of the trial, okay? Somebody with an acute subdural or somebody with a neurologic devastation from a chronic subdural, go to the OR, take care of them. Don't worry about embolization. There are some patients that come in where I look at them and I think, yeah, you need to be drained. You have a major problem. There's mass effect. But I can do it tomorrow. I don't need to do it tonight. Those can be enrolled to see if preoperative embolization makes a difference. So we're going to randomize patients either pre-op embolization or no pre-op embolization. And then the third group are those which have some complaint or deficit and a chronic subdural, but they're not terrible. They're a Glasgow Coma scale of 15. You can wait. You can see if you can get them through. And those will be randomized to either best medical management with embolization or not, 1-to-1 randomization. So here's the nomogram showing these, three buckets and how we are only randomizing for patients who have either the potential to be treated with non-emergent drainage or conservative management. The primary endpoints are efficacy defined as residual subdural more than a centimeter on the 6-month scan or reoperation, or a safety failure because they had a major disabling stroke, MI, or death from any cause within 6 months. Secondary endpoints, we're going to be looking out for a year. We're going to be looking at modified Rankin scale, death within 3 months, hospital days, ICU days, quality of life, and then full neuropsychological testing, which I'm excited about because we don't have very good data on this. So this is an example of a way where vascular neurosurgery and neurointervention can evolve. I guess the other big trial that I'm working on that I'm excited about is looking at surface modified pipeline, the pipeline shield for ruptured dorsal carotid blister aneurysms, because I think this issue of anticoagulation in patients is very important. So as we work out new ways to expand our field, in my thinking, using a minimally invasive approach to chronic subdurals is a way of treating patients who are older who need to be on anticoagulation. And the mirror image is for patients with a bad ruptured blister aneurysm or wide aneurysm. I'd like to be able to put a flow diverter in without having to have them on dual antiplatelets. So it's a population I don't want on anticoagulation and a population that does have to be on anticoagulation, trying to find novel neurointerventional solutions to lower morbidity and mortality. So that's my whole presentation. I wanted to keep it relatively short so that if you have questions or criticisms, I can answer them.
Let me check the chat for any question, doctor.
Thanks,
congratulations for your amazing talk. One of the questions in our internal internal chat is what about the reimbursement of the procedure in the United States? Because the neurosurgical community are afraid with the cost of the procedure and how is the process to introduce in the system. What about the reimbursement for the procedure in the US? Have you any trouble with this?
No, I have never heard of anyone in the US having reimbursement denied for this procedure. Now, if it becomes much more common, insurance companies are the devil. So maybe they're going to do something in the future. But for now, we use an existing code for embolization of branches of the external carotid artery, intracranial embolization branches of external carotid artery, and it reimburses quite well in the US at least. So that has been good.
Another technical question is about the balloon augmentation technique. Did you mention any specific situation where the balloon would be very, very useful? But most of the physicians, especially the neurointerventionalists, prefers to use the balloon augmentation technique in order to avoid any reflux or reducing the exposure time or the amount of the liquid embolic agent, trying to get an early it's not necessary to use the tapoon or the block and push technique. Do you recommend the use of balloon augmentation technique for any procedure, or just under the situation that you mentioned before?
Yeah, so for me, just my opinion, if I can get a microcatheter wedged very, very distally, okay, all the way out, then I don't need the balloon because it's going to go forward and you're already where you need to be. So I don't need the expense of the balloon. I don't need the stiffness of the balloon. In the case I showed where I can't get distally, that's when I use the balloon. So the balloon for me is only if I can't get out distally with a microcatheter. If I can get out distally with a microcatheter, I think that's superior because I want to be all the way out over the convexity. And because those branches always get smaller, you can always wedge a microcatheter, right? You can always get to a point where the microcatheter is stuck and wedged, and then, of course, you don't need a balloon.
Another question here is, besides the ophthalmic undesired embolization, what is the other frequent complication for the procedure?
Embolization of the petrosal branch at the skull base, which can go to the vasa nervorum of the facial nerve. So the complications that have been described, and as I said, I don't have this complication yet, is either the eye or the facial nerve inadvertent embolization. Of course, it's an endovascular procedure, so you can get a groin problem or other problems. I see a question, what percentage of cases will need drainage? You know, it's a great question. I don't know the answer yet. I'm still trying to figure out who we can get away with without drainage and who we have to drain. I have had some failures where we've done embolization and the patient continued to worsen and we needed to drain them. So I guess when they have very large subdurals with a lot of mass effect and a significant deficit, in my opinion, those are the patients who are more likely to need drainage. But because it's a randomized controlled trial, my hope is we're going to have good data, right? It's not always possible to do a randomized controlled trial. So for instance, I did the web trial. It's just a single arm trial. You don't have a comparison. In this, we're going to have a comparison. So we'll see failure rates. We'll see what the failure rate is for embolization versus without embolization. So I can answer your question better in maybe 1 year.
Of course, of course. A couple of days ago, when we started the publication of your talk, one of the physicians here in Colombia talking about the Chinese trial using statins and steroids for the management of chronic subdural hematoma. Have you heard something about it? Or...
Yes, it's a very interesting idea. And I think it makes sense given the molecular pathology I presented. not got any experience curing subdurals with steroids, but I can tell you that in this randomized trial for embolization, I want to make sure that if a center is using steroids, they're doing it in both arms, right? So that we don't have confounding or a problem there. I don't know this answer yet, whether steroids will work, but I think it's a real question.
Great, great. Okay, Professor Adam, just one more thing. Today we are celebrating the World Stroke Day. Everybody is fighting against stroke. From your personal point of view, what is the role of the neurosurgical community in the current management of the stroke pathology? Yeah, you know, it's a devastating condition, and just a very, very interesting message about the management of stroke.
So, you know, all over the world, there are different training pathways. And so I have colleagues that do this work in embolization who are surgeons. I have colleagues who are neurologists. I have colleagues who are radiologists. I'm a surgeon. So I started with clipping aneurysms and removing AVMs and doing brain tumors and spine surgery, and then learned embolization. And so among neurosurgeons, I am what I sometimes call a stroke surgeon, right? I only focus on patients who either have had a stroke or I'm worried they're going to have a stroke. And it could be hemorrhagic stroke from an aneurysm, or it could be ischemic stroke. So I see a big role in the future for people like me, stroke surgeons. I'm working to train some young surgeons, and they're all going to be much better and smarter than I am. They're going to have better hands. They're going to have better tools. They're going to do a better job. So I see a big future for stroke surgery, for neurosurgeons who are fully trained in how to handle all kinds of surgical problems, but they really focus on a patient who is having a stroke or is at risk of having a stroke. So I'm excited about that. I'm not trying to say that only neurosurgeons will be stroke surgeons. Obviously, you can come to this field from different directions, but I do think that neurosurgeons have a major role to play, and I love our work. You know, 2 nights ago at 3 o'clock in the morning, waiting for the patient, I did not love my job in that moment. But when you can really help somebody and send them back to their lives, back to their families, it's a good feeling. So I'm very excited for the future of the field. So many young people from all over the world have great ideas. And so I want to be part of a very alive, vibrant, growing discipline. And that's where we are. I mean, this is a field that's exploding. It is not only the most exciting field in neurosurgery or neurosciences, it's the most exciting field in medicine, is advances in vascular neurosurgery and what we can do. And so, you know, in 20 or 30 years, you know, maybe we're not just treating aneurysms and AVMs and stroke. We're not just treating aneurysms, AVMs, chronic subdurals and stroke. Maybe we're treating movement disorders. You probably saw yesterday in the Journal of Neurointerventional Surgery, Tom Oxley and his group showed 2 cases where they put a stent in the sagittal sinus that has electrodes on it that can transcribe motor signals in patients who are locked in and paralyzed. So there's 2 men now in Australia that were completely locked in who now can call their wife, shop online, type using only transcription through a stent in the sagittal sinus. I mean, this is amazing. It's almost like science fiction. So I'm very excited about stroke surgery and the future.
Perfect, perfect. Your answer is really illustrative for us. We have a mandatory question for you. Part of the answer did you respond? But what is in your personal point of view? What is the future of the neurovascular surgery in terms of the microsurgery for very, very challenged technique like a bypass, intracranial bypass? Still there is a space for this kind of techniques, or what is the future of microsurgeons? What is the future of the top of the microvascular neurosurgery? So would be necessary of most of the techniques are evolving to solve all the issues that we will need a very training microsurgeon.
It's a good question. I think the future is good. I don't think microsurgery is going away. I think it's important, and I still train very carefully to be a good microsurgeon. I do bypasses in rats. I work with a very good group, and I do microsurgery every week. I guess for a young person who's going into this field, maybe they would ask, how shall I train? How shall I base my field? And I guess my advice is, it's very good to become a specialist in a disease and learn how to use all the tools to treat that disease. So that's my approach. I'm very good friends with Michael Lawton at the Barrow. Michael's entire field is a tool. It's microsurgery, and he's fantastic. I love to watch him operate and learn from him. But I think he's training people. So his fellow right now is a guy named Vishwas Srinivasan. He's training people who are doing endovascular and microsurgery. So when I came out, I was told you can't do both. You're not going to be as good as Jacques Moret and also as good as Robert Spetzler. I didn't listen. I'm going to do the best I can to be a very good interventionalist and a very good microsurgeon. And so far, I'm able to do good things for my patient. I'm very happy. So you can all decide your own path, but my advice is don't only use one tool. You know, you don't want to be a carpenter who only knows how to use a hammer. You want to be the best carpenter you can be, which means focusing on the patient. Be a stroke surgeon rather than just a catheter surgeon or just a bypass surgeon. Now, that's just my advice. Obviously, if you decide that you're only going to do, you know, STA to MCA bypass, it's your only thing you're going to do, you're probably going to be very, very good at it because repetition is so important. Practice is so important. But I think you can be good at more than one thing.
Thank you, Adam, for your commitment, for your participation here in our Super Thursday. Let me ask the audience if any extra question, please, okay? ¿Alguna otra pregunta para el profesor, doctor Cabe, que lo veo por ahí?
Oh, yeah. Quite interesting your approach for the neurosurgery in a very old illness. And congratulations, because you have found a new and safe procedure for an illness with a standard treatment since ages. Your images and results are convincing. And I hope you get a general acceptance. It's quite difficult because you know that when everyone thinks the same, it means that no one is thinking. That was a phrase of Walter Lippmann. So congratulations again, Dr. Adam. Very pleased to hear your speech. Thank you very much.
Thank you.
And I hope good news in the future.
Well, we're going to see. I mean, that's the important part of doing science. If it fails, I still think the trial is good work. You know, you learn something from testing it.
Okay, ¿alguna otra pregunta? Ignacio.
What is amazing. Descrestador. Me gustó mucho. Muchas gracias.
He's the chief of the director of the neurosurgical department. He's really excited with your talk. And for us, it would be a very illustrative talk. What would be the next step for the endovascular surgeons? Your answer about the neurosurgical community is really, really interesting. Professor, now just to say congratulations. We really appreciate your support. Probably just hope that you will join in a future for another interesting topic.
Thank you, Ignacio. A pleasure. I'm very grateful. Thank you for your kind words.
¿Algo más? ¿Algo más? ¿Alguien quiere preguntar algo más?
Ori, no, nada, nuevamente, muchas gracias. Qué conferencia tan interesante y tan novedosa. Esperemos que esto resulte y que sea un nuevo campo que se abra la terapia endovascular.
Ok, Ignacio, gracias.
Estamos muy emocionados con esto.
Bueno, Ignacio, no, gracias.
Gracias. Chao.
Okay, Professor Adam, thank you very much. As I've mentioned before, probably we will invite you to participate in another interesting topic in the future. Thank you for share your investigations, your research about this topic, the interesting topic. See you around, Professor.
Thanks, Boris. Gracias. Thank you all. Goodbye.
Nice Spanish.
No.
Okay, goodbye. Thank you very much.